Hi, I'm Dr. Tom Kravis, Physician Executive for 3M Consulting Services. Thank you for joining me. Today we're going to talk about ICD-10 documentation for rehabilitation in orthopedic aftercare. There are some changes you will need to make in your documentation to support ICD-10, but there are instances of documentation that can remain the same. We'll help make you completely functional with ICD-10 in no time at all. So let's get started. I know you are busy in your clinical practice, so I will briefly summarize the key takeaways. In your documentation of patient care, consider the use of adjectives. Link the cause and effect of each condition. Be specific about aspects of a disease and each anatomical site, and use exact dates when appropriate. A little more on each of these. Differentiate in your notes whether or not a condition is acute, chronic, or acute on chronic whenever appropriate. For example, write acute on chronic congestive heart failure rather than congestive heart failure. Use due to or secondary to indicate cause and effect, and to record all conditions the patient may have, such as cerebral infarction due to thrombosis or peripheral angiopathy due to type 2 diabetes. Think about the most current terminology to describe a condition or different aspects of the disease. For example, spastic diplegic cerebral palsy. Precisely designate anatomical sites such as embolism of right anterior cerebral artery. Ask yourself, what else could I add in my notes about this patient's condition that would better communicate how sick the patient is, which in turn better communicates the resources needed for patient care. Incorporating these aspects into your documentation will result in an accurate picture of your patient's severity of illness and risk of mortality. This in turn will result in accurate public reporting on quality and outcomes. And it will help reduce the number of queries you receive to clarify your documentation. In the upcoming slides, we'll take a look at some diseases and procedures that have new documentation requirements under ICD-10. In ICD-10, there is a feature called laterality for right, left, and bilateral, which is found in many diagnoses and procedure codes involving paired organs, or those codes specific to one side of the body versus the other. For example, acute left otitis media. ICD-9 has a limited number of these. ICD-10 has many more. This feature of ICD-10 by itself is responsible for a substantial increase in the number of codes which you have probably heard so much about. Since you usually include this information in your patient care notes, additional documentation will typically not be needed. So for your information, if you happen to omit laterality when needed, it may result in a query. Suffice it to say, laterality is included when appropriate for some conditions you may treat. For example, pressure ulcer of the left ankle. So do a quick double check of your notes to be sure you included it before signing off. We'll try not to belabor this point in the upcoming slides. What stays the same? The etiology of cerebral infarction or stroke is still classified primarily by whether it is due to thrombosis or embolism. What's new? ICD-10 has lots of new codes for cerebral infarction which identify the specific artery involved and, when applicable, whether right or left. For example, you see here the codes for cerebral infarction due to thrombosis of the anterior cerebral artery. Keep in mind, coders can't get the details of the etiology, site, or laterality from ancillary services reports, such as radiology, since coding must be based on what you document. So be sure to include these details in your notes. Also new is that ICD-10 provides codes for a cerebral infarction that occurs intraoperatively or postoperatively during cardiac surgery or another type of surgery. It's important to make sure your documentation clearly indicates at which point in time the infarction occurred. As with cerebral infarction, additional documentation that will be needed for patients with non-traumatic subarachnoid hemorrhage is the artery affected, as seen here on the left. Documentation of sites other than artery, such as parietal, results in a query or the reporting of a code that states unspecified intracranial artery. As seen here on the right, non-traumatic intracerebral hemorrhage requires documentation of the portion of the brain affected, such as the subcortical or cortical hemisphere. As you can see here, ICD-10 provides different codes for a non-traumatic subdural hemorrhage specified as acute, subacute, or chronic. Once again, ICD-10 allows you to report how sick your patient is through the reporting of acuity, so be sure to differentiate the type in your notes. Also note, code I62.1 is reported for non-traumatic extradural hemorrhage when documented. Unique ICD-10 codes are reported for traumatic brain hemorrhage of the sites you see here when you include this information in your notes. Additionally, you have the capability to report any associated loss of consciousness and how long it lasted. For example, one code is reported for loss of consciousness up to 30 minutes, a different code is reported for up to 59 minutes, and so forth. So include this information in the patient record. In addition to documentation of laterality, conditions such as monoplegia, hemiplegia, and other paralytic syndromes also require documentation of whether the dominant or non-dominant side is affected. Dominant versus non-dominant side could also be reported in ICD-9, but we mentioned it here because it continues to be a documentation improvement opportunity. Should you document right or left, but you don't specify whether it is dominant or non-dominant, the right side defaults to dominant and the left side defaults to non-dominant. Since the side involved is important in determining potential for recovery, we need to be sure the correct side affected is coded and reported. As an FYI, because we know you usually document this, ICD-10 provides increased specificity to report the exact part of the spinal column affected, as seen here for spinal column diseases and conditions and intervertebral disc disorders. ICD-9 had only limited capability to identify the part of the spinal column affected. As mentioned earlier, for diseases of the spinal column, ICD-10 provides the ability to report the specific site of the spinal column affected. The site designations are a bit different for spinal cord injuries. For cervical and lumbar, you should document the specific vertebral segment affected, such as C3 or L3. However, a range can be used for thoracic injuries, with the exception of those that occur at T1. Take a moment to review these on the screen. We know that you typically document this, especially during the early encounters, but this early detail may not be recorded in later encounters, especially during hospital visits. Coders must use documentation from the current encounter and are not permitted to look back at previous visit information to determine the code, which makes it important that you record a complete diagnosis during each patient encounter. ICD-10 codes distinguish between open and closed and displaced and non-displaced fractures. In some cases, unique codes are provided for the specific part of the bone fractured. For example, greater or lesser trochanter of the head of the right femur. Fracture orientation can also be specified, such as green stick, transverse, oblique, or spiral. And of course, right versus left when applicable is also a component. So be as precise as possible when recording your diagnosis of fracture. For open fractures of the forearm, femur, and lower leg, you will also need to document type 1, 2, or 3A, 3B, or 3C according to the Gustillo classification. As you know, the Gustillo classification is used to identify the severity of soft tissue damage. Fracture healing, infection, and amputation rates correlate with the degree of soft tissue injury by Gustillo and help determine the prognosis. Physial fractures are reported based on the Salter-Harris classifications of types 1 through types 4. Finally, sacral fractures need the additional description of zone 1, 2, or 3 for vertical fractures and whether minimally or severely displaced. Transverse fractures are reported based on types 1, 2, 3, or 4. As seen here, ICD-10 has 5 groups of codes for osteoarthritis. The first group, polyosteoarthritis, only requires documentation of the type, such as primary generalized polyosteoarthritis. The next 3 groups of codes are specific to the site affected, hip, knee, and the first CMC joint. Unique codes can be reported for these sites to indicate the type as primary, post-traumatic, or other secondary, and then whether the right or left or both are affected. The final group of codes classifies other types of osteoarthritis that is not polyosteoarthritis or is not of the hip, knee, or the first CMC joint. Unique codes that include laterality are provided for shoulder, elbow, wrist, hand, and ankle and foot. So think about the story your final diagnosis tells of the patient's condition. For example, osteoarthritis or post-traumatic osteoarthritis of the left wrist. Obviously, the latter tells the better story. Keep in mind that a joint replaced by a prosthesis no longer is considered to have osteoarthritis or other arthritis, even though this condition was the reason for the joint replacement. What's new for rheumatoid arthritis? ICD-10 has 3 categories of codes which provides the ability to differentiate between 3 types: RA with and without rheumatoid factor, rheumatoid bursitis and rheumatoid nodule, and juvenile RA. Each category provides anatomical site and laterality specific codes. Additionally, RA with rheumatoid factor has unique combination codes for associated complications such as rheumatoid heart and lung disease. Obviously, this level of detail requires more of a diagnostic statement than just rheumatoid arthritis. ICD-10 provides you with the opportunity to really tell the story of a patient with a condition that can last for decades. And it is one that is easily told when your diagnostic statement identifies the type of RA your patient has, anatomical sites involved in laterality, and any associated complications. As in ICD-9, ICD-10 provides codes to identify patients with 1 or more joint prostheses. As you can see on screen, the only difference is that ICD-10 codes provide additional specificity for laterality. Not seen here are the codes for presence of artificial joints of the shoulder, elbow, wrist, and ankle. Just like in joint replacement status, as in ICD-9, ICD-10 provides codes to identify patients who are status post-amputation. As you can see on screen, again, the only difference is that ICD-10 codes provide additional specificity for laterality. Additional codes not seen here are provided for status post-amputation of other parts of body, such as toe, foot, and upper limb. A diagnosis of peripheral vascular disease, peripheral angiopathy, or peripheral arterial disease not further described is assigned to a non-specific code in ICD-10. Although we usually mean atherosclerosis of the arteries of the extremities when we document peripheral vascular disease, the coder cannot make assumptions. Document your diagnoses as specifically as possible. For example, atherosclerosis of arteries of the right leg with ulceration, or peripheral angiopathy due to diabetes type 2 with gangrene. In ICD-10, burns are classified in much the same way as in ICD-9, by anatomic site and depth or degree of burn, that is, first, second, or third degree. Burns of the eye and internal organs are classified by site, but not by depth or degree. What's new in ICD-10? A distinction is made between thermal burns and corrosive burns. Corrosive burns are due to chemicals. Thermal burns are due to a heat source such as flame, hot air, or gases, and electrical heating appliances, among others. To summarize, your documentation of burns should include anatomic site, degree, and cause. Additionally, you should document the percentage of body surface involved with any degree of burn, and of that percentage, how much is third degree. As in ICD-9, ICD-10 continues to classify CAD by native coronary artery or bypass graft, and if the CAD is of a bypass graft, the type of graft. These should already be elements of your documentation. What's different in ICD-10? Combination codes are provided for CAD with and without angina. When your patient has CAD with angina, your documentation of angina should include the type, if other than angina pectoris, such as unstable angina or angina with documented spasm. For example, ICD-10 code I25.710 is reported when you document CAD of saphenous vein bypass graft and unstable angina pectoris. As in ICD-9, ICD-10 classifies myocardial infarction by type, STEMI versus non-STEMI. New in ICD-10 is the ability to report the site or location of a STEMI by coronary artery affected. If at the time of diagnosis you don't know the coronary artery, document as much as you do know, such as the wall of heart affected. Note that no additional documentation is needed for the location of non-STEMI. ICD-10 terminology describing congestive heart failure remains essentially unchanged from ICD-9. However, there is currently an opportunity for improvement in documenting this diagnosis. To provide an accurate picture of the patient's severity of illness and risk of mortality, you should specify whether the patient's congestive heart failure is acute, chronic, acute on chronic, and whether it is systolic, diastolic, or a combination of both. Additionally, you should document the cause or etiology of the congestive heart failure when known or suspected. An example of excellent documentation would be acute systolic heart failure due to possible or suspected alcoholic cardiomyopathy. The only thing new here is that ICD-10 combines the anatomical site and the stage of the pressure ulcer into a single code. This required 2 codes in ICD-9. As you may be aware at this point, coders can use nursing or physical therapist documentation for the stage of the pressure ulcer, but you must document the diagnosis of pressure ulcer in your notes in order for it to be coded. It is also important to indicate if the pressure ulcer was present at the time of the patient's admission. ICD-10 differentiates COPD with acute lower respiratory tract infection from acute exacerbation of COPD without infection. When an infection is present, document the specific infection and organism when known or suspected. When respiratory failure is present, it should be specified as acute, acute on chronic, or chronic. Dependence on supplemental oxygen should also be indicated when applicable. Most types of emphysema were grouped into a single ICD-9 code. What's new in ICD-10? Separate codes are provided for specific types of emphysema. When you document the specific type of emphysema, such as unilateral, panlobular, or centrilobular, a unique ICD-10 code for that condition can be reported. ICD-9 did not differentiate between a diagnosis of respiratory failure and acute respiratory failure. The good news is that ICD-10 does. When appropriate, you should document respiratory failure as acute, chronic, or acute on chronic. Additionally, also specify if hypoxia or hypercapnia, or both, is associated with the respiratory failure. Remember, coders cannot interpret the results of tests such as arterial blood gases. They must rely on your documentation. At times, we see respiratory insufficiency and respiratory distress used interchangeably with respiratory failure. Respiratory insufficiency and distress are signs and symptoms of an underlying condition and are coded differently from respiratory failure in ICD-10. Be clear on your intended diagnosis. Severity of illness will not be reported accurately if you use one term when you mean another. Additionally, document the cause or etiology of respiratory failure, such as due to COPD, surgery, or trauma. What's new here is that a diagnosis of depression without further qualification is coded to F32.9 in ICD-10, which is the code for major depressive disorder, single episode, unspecified. In ICD-9, a diagnosis of unqualified depression was assigned a code that simply said depression. If major depression is not your intended diagnosis, consider adding additional details to your documentation when known. It will change the code and better describe what you are treating. For example, major depression could be further specified as single episode or recurrent. In either case, is it mild, moderate, or severe? If severe, it is with or without psychotic features. Is your intended diagnosis something else other than major depression, such as adjustment disorder, for example, grief reaction, with depression and or anxiety, depression, or depressive neuroses? According to published Medicare inpatient hospital data, the code for unspecified depression appears on 1/5 of hospital records covered by Medicare. We can do a better job identifying patients with major depressive disorders as compared to those with other forms of depression that are less severe and require less resources. Given the health risks of obesity and the number of obese people, it is important for us to be able to continue to track the prevalence and cause of obesity among U.S. adults and children. Since overeating is the #1 cause of obesity, it should come as no surprise that ICD-10 has a new code for nutritional obesity, or obesity due to excess calories. So consider incorporating nutritional obesity into your vocabulary when applicable. It's a few less words than obesity due to excess calories. If your patient has morbid obesity, also document if alveolar hypoventilation is present. ICD-10 has a single combination code for it. As in ICD-9, ICD-10 continues to classify obesity due to other causes, such as due to drugs or endocrine disorders. There are no changes here. However, we mention BMI because it is used in studies to predict the likelihood of success of joint replacement surgery and how well the patient may do after surgery. When you consider BMI an important patient characteristic, including this information in your notes will increase accurate and consistent reporting. ICD-9 provided a single code for tobacco abuse and dependence without differentiation and without further specificity for the type of tobacco product. ICD-10 provides separate codes for these. If your intended diagnosis is dependence, dependence is what you should document rather than abuse. According to the Centers for Disease Control and Prevention, most smokers are dependent, and nicotine dependence is the most common form of dependence in the U.S. Additionally, further specificity is provided in ICD-10 for the type of tobacco product dependence, as cigarettes, chewing tobacco, or other, for example, cigars, so this should be documented as well. Your documentation should differentiate between current abuse or dependence versus a person who no longer uses tobacco. Starting in 2002, the number of former smokers has exceeded the number of current smokers. For tobacco dependence, ICD-10 provides the ability to report remission and withdrawal. Examples of nicotine withdrawal symptoms include irritability, anxiety, difficulty concentrating, and increased appetite. ICD-10 also provides the ability to show a cause and effect relationship between tobacco dependence and nicotine-induced disorders when documented. Finally, your notes for a patient's exposure to secondhand smoke can be converted to an ICD-10 code that says exactly that. ICD-10 requires more detailed descriptions in your documentation of anatomical site and aspects of a disease, condition, procedure, and circumstances of patient encounters. The information generated from ICD-10 codes will result in a more accurate picture of your patients, their severity of illness, risk of mortality, and the services rendered. This in turn will result in accurate public reporting on quality and outcomes. Should you have questions about documentation for a particular diagnosis or procedure, your hospital's clinical documentation improvement specialist should be your first stop. The coding staff in your Health Information Management Department is a valuable resource as well. Thanks for joining me, and have a great day.